All right. Apologies. It sounds like you have not been able to hear me speaking. So I'm just checking again now. Can people hear me speaking?
Yes, we hear you now. Thank you.
If you could just let me know in the chat box if you're able to hear me. Great. So apologies there. I think I was talking into a uh, into the computer with no sound. So thank you for your patience. So just to recap what I was saying, um, the vision for these modules is that they're interprofessional, that they facilitate you as educators to bring together learners from different professions, with the ultimate goal that all of us are committed to seeing the next generation of healthcare professionals across sub-Saharan Africa deliver high quality team-based HIV care. And again, sincere apologies that you weren't able to hear me. What I'm going to do is kick off now with a brief discussion of some interprofessional communication vignettes or pearls. And then my colleague Judy Cagnola is going to talk about module 11, and then Clara from the University of Zimbabwe is going to talk about module 12. So let me take myself off video and then I'll begin. So I don't think I need to tell this audience the importance of effective interprofessional collaboration to delivering high quality team-based care. You know, the American Academy of Physicians estimates that ineffective communication are the root cause of 2/3 of all adverse sentinel events, at least in the US healthcare system, and I'm sure that that is true elsewhere too. Moreover, effective communication is the sort of the bulwark against medical errors. And when we're talking about effective communication, we're talking about complete communication, clear communication, brief and timely as sort of elements of what we understand to be effective communication. So complete, communicating all the relevant information, clear, conveying information that is plainly understood, brief, communicating the information in a concise manner, and timely, in terms of both the brevity of the communication and and the veracity of that communication. So just to sort of emphasize this point, when we're talking about brief communication, avoiding obfuscation, avoiding too much jargon is essential. I think in the healthcare professionals and particularly physicians, we have a tendency to using too many words, particularly in those high stress situations where brevity and succinctness is of importance. Moreover, I think we often have a tendency to saying things in a way that sort of compounds the lack of clarity. And oftentimes, things are said after the event or, in a way that is not relevant to clinical practice. So brief, clear, timely communication is essential for high quality care. There are many tools that can be employed to enhance the quality of communication that is delivered in an interprofessional format, and often can also enhance the team-based elements of team-based care. And HRSA and AHRQ, which is a US agency that is committed to improving quality of the healthcare in the US, have come up with a great number of relevant resources that can enhance communication in the clinical setting. And all of these can be found if you navigate to their website, the TeamSteps website, which gives examples of tools that are at your disposal that you can practice in both in your clinical practice and teach your trainees to learn more about. And here where I'm currently at work in the hospital where I practice, and these tools are actually posted on the walls and next to the computers where the doctors work or at the nurses' stations, so that these kind of techniques are sort of established and used as clinical practice. And I'm not going to go into specific detail in many of these, but I would encourage you to look through these on the Team Steps website, and I can send out that link to those. But these are examples of tools that can be employed to improve team-based care. And I just want to talk specifically about the SBAR, and that's because we use this tool in a couple of modules, including in one of the modules that is going to be presented later today. And many of you may be familiar with the SBAR. It's an acronym that you can teach your learners, but it provides an important framework for how team members can effectively communicate information to each other. And we think that this is a tool that could improve communication around HIV clinical practice. Moreover, in situations where roles are very hierarchical, where it's often difficult for nurses and particularly nursing students to have the sort of the power in the sort of interprofessional dynamic to speak up for themselves, this kind of tool can be a useful way to capacitate, to empower nurses to speak up. So what is SBAR? So it's basically a framework for talking about any particular clinical vignette. And so we encourage the learner to think through what is the problem and in the setting of these four elements. What's the situation? What's happening right now? What do you want to communicate? What's the background to that situation? So for example, what's the clinical context for your communication with another healthcare professional? Is it something to do with the patient being sick or a medical prescription that needs to be completed? What's the assessment? What do you think the problem is? How has it arisen? And then fourthly, what is the recommendation? What would you recommend? And the goal of this framework for communication is that you're able to deliver in 60 to 90 seconds the key components of the clinical vignette that you want to communicate, whilst removing jargon and the potential influence of hierarchy and personality that can play an important role in how we communicate with other healthcare professionals. And I think importantly, this approach is useful because in many situations, it's nurses that are frontline care providers, and it enables them to act as the advocate, protecting patients from further harm, and yet speak in ways that empower them to communicate with physicians, often in situations and cultures where they're not typically empowered to play those roles. And so I think, our hope is that the SBAR becomes a useful tool for nursing students in particular to gain confidence, to address potential miscommunication and increase patient safety. And hopefully, as is the case here and where I practice, using the SBAR will allow healthcare professionals to move beyond traditional approaches of merely reporting information into newer domains of practice around joint decision making, including providing opinions and making recommendations, which is part of optimal team-based care. Just wanted to sort of cover very briefly another example of interprofessional communication, an acronym. This is referred to as CUS, and it's a tool that can be used when healthcare professionals are concerned that there may be a safety breach, and it can empower providers to stop the line if they sense that there is some deficit in quality that needs to be addressed. And again, it's about equipping healthcare professionals that may not feel that they have the power or the confidence to address an issue by giving them language to do that. And this is something we want the modules to address so that the learners understand these techniques. So CUS, basically CUS, concern, uncomfortable, safety. I'm concerned, I'm uncomfortable, there's a safety issue. And it's a way for learners to be able to articulate where they feel there are deficits in care that need to be addressed. We will cover this and other interprofessional tools for communication later on in the webinar series. But this is what I wanted to kick off with today. I'm happy to answer questions, and I can share with you in my follow-up email the link to the TeamSteps website, which includes more of these things. But without further ado, let me hand over the microphone to my colleague Cheyenne, who's going to lead for the remainder of the call.
Thanks, Mike. So to start, we have Judy, who's the author and will be reviewing Module 11, which is on PrEP and the care for MSM. Judy? I'm gonna unmute you. Okay. Judy, can you test your volume?
Hi, do you want me to start?
Yes, please, go ahead, thank you.
Thank you very much, Cheyenne, and thank you so much, Mike, for that very, very appropriate introduction. Module 11 looks at primarily men who have sex with men, and at this juncture, I'd just like to just reiterate for colleagues on the line regarding the delivery of this module to our students and to amongst us as health workers that this is particularly one module where interprofessional education and collaboration is so key, especially for us here in Africa, simply because a lot of these issues that are around men who have sex with men are not very easy to talk about within our context in Africa, which predominantly is quite conservative, especially on issues related to sex, and more so sex of, let me not say non-traditional, like the category where men who have sex with men fall. So it's very, very critical for us to really, really model and teach an interprofessional collaboration, and where Mike has said very well as a link to this particular module around communication. So as we know that IPE broadly is just, defined as the partnership between a team of health professions or health professionals and the client in a collaborative approach. And we know in this instance of men who have sex with men that this is very, very critical, especially because this is a category of people for most of us here in Africa who we are only beginning to understand and beginning to I want to say even come to terms with. So the view of the client is very, very important for us to be able then to provide good quality HIV care. One of the key characteristics of team effectiveness that Mike has mentioned is open communication. And again, for this particular module, this is very critical. And Mike actually alluded to this when he said that poor IPE can actually have a very negative impact on the quality of patient care. And again, I just want to reiterate, this is even more so for this particular category of patients who are hidden, who are criminalized. In many African countries, they are actually, they're chased, they're jailed, they're, put in jail and criminalized. And therefore, it's very, very important for us to have open communication. So the goal of this particular module 11 is to prepare learners to provide and promote equitable HIV services to key populations. Again, here I just want to stop and say that key populations, technically, we talk about this particular group as those people who have an elevated risk or a burden of HIV due to one reason or another. And here on this module, we zeroed in specifically to men who have sex with men, because this is a population that unfortunately, due to the criminalization, the stigma and the prejudice and the ignorance around this particular, I want to say, lifestyle or behavior, it's not easy for them to seek medical care or health care. And so we want to do this with empathy, without prejudice, and in the process, we also want to acquire skills in increasing comfort with taking a sexual history. So our vignette, like has happened in all the modules that have been presented in these webinars, is Joseph, and he presents to the outpatient department with painful defecation and an anal discharge. He's had anal receptive sex with men in the previous 2 months. He lives 25 kilometers away, but he has traveled to this particular OPD because he knows here nobody knows him. He's anxious about being asked questions and being examined by a nurse in a crowded and open space, as you know, in most of our health care settings or hospitals, dispensaries, and health centers. And he's very apprehensive about explaining his sexual activity once more to the provider. So here we have a patient who is Joseph, and we have a provider. Typically, it can be a clinical officer or it can be a nurse, and in sometimes even more of the urban settings, we also have medical doctors who would be able to meet Joseph, sorry, not John. Next slide. Has something gone wrong? I can't see it very well. Thank you. So the objectives are here. We have objective number 1, which is recognizing the needs of key populations. And here I just want to say that key populations are not just men who have sex with men, although this model is focusing on them. We have a whole other gamut of key population, which range from female sex workers, commercial sex workers, long distance truck drivers. We have now why am I forgetting? Sometimes even fisher folk are counted in there, people who inject drugs and so on also fall into that category of key populations. So we are looking at their needs and the need to ensure access to health services for them in order to address the HIV epidemic. We need to recognize the underlying prejudice towards this key population, men who have sex with men, female sex workers, for example. All these always tend to have an underlying prejudice, including ourselves as healthcare providers. We do also have a lot of provider bias. So here we want to discuss stigma and discrimination, underlying biases towards men who have sex with men, and what health workers can do to challenge this stigma and discrimination. We want to demonstrate how to take a sexual history in a non-judgmental way, which often, I know most of us when we went to school, we were not taught how to do this very well. And yet now as we come out into the clinical area, we need to get this information from this particular group, and we have to do it in a non-judgmental way, not the way, you know, you just want to go out and ask somebody, when did you last have sex? Who did you have sex with? So here you're going to watch and assess videos portraying a problematic versus non-judgmental sexual history. So literally showing you the good way of doing it, the bad way of doing it. And so we take away the message that we need to do the good way, not the bad way. Identify indications for PrEP, that is pre-exposure for prophylaxis, and discuss PrEP as a prevention method for people who are at substantial risk for HIV, where men who have sex with men fall. Describe a PrEP regimen, and last but not least, describe an STI screening plan for this key population, which includes lab tests and other diagnostics for STI and so on, and of course, in addition to counseling. Next slide. So the 5 Ps. The 5 Ps is a learning tool or a framework that we use, that we have used within this module to take a sexual history. And it refers to the domains that should be openly discussed with patients. So when we are looking at taking a sexual history, you want to discuss, number 1, the partners of the patient. We want to discuss the practices. And oftentimes, many times, it's the actual sexual practices. So like in our vignette, we looked at anal receptive sex. That's a sexual practice. So discussing those types of practices that people do is not very easy, but we must bring it out because we know that HIV is transmitted through a lot of these particular practices. Then third P is protection from STIs, past history of STIs, and last but not least, prevention of pregnancy. Next slide. So the key questions we are asking within this module is, what learning methods are we going to employ to ensure that we achieve the objectives of this module? What is the core content that we are trying to communicate? And here we are really looking at HIV prevention. We are looking at social cultural issues. And like I mentioned before, we are looking at communications. And then what are the essential IPE tools that we are deploying? And what is the QI method addressed in this module? So when we are looking at, for example, one of the things that I always say when we are talking about men who have sex with men is that stigma and discrimination are very key, not only in preventing key populations from accessing health services, but even in their management and their care of treatment, and also in fueling the transmission of HIV. Often it's very critical to know that men who have sex with men also have female partners, especially in this part of our world in Africa. Many of the men who have sex with men have female sexual partners, unlike other populations in other parts of the world where men who have sex with men predominantly only have sex with men. In Africa, men who have sex with men often have female sexual partners. And this therefore fuels the spread of the HIV epidemic. So it's very, very important for us to look at the three things highlighted there, the issues around HIV prevention, the socio-cultural issues, and very, very critical and important, communication. Next slide. I think that's it. Yeah, that's it.
Great job, Judy. Thank you so much. And so next we'll have Clara, who did module 12 for the adolescent male with perinatally acquired HIV. Clara, let me test your volume. Okay, Clara, can you go ahead and speak?
Hello, can I start?
Yes, great.
Hello, good afternoon. Okay. In module 12, we are looking at the care for the adolescent male with perinatal acquired HIV.
I'm just gonna go ahead and point out that the case has been updated here. So Claire, you can just point out the updated age.
Okay, yeah, the age has been updated. You know, we've changed it from 13 to 17. Okay, the goal of this module that we're looking at is to introduce learners to concepts around the care of adolescent male with perinatal acquired HIV, so as to recognize contextual factors to best support these patients and promote their quality of life. We are focusing mainly on these patients that have acquired perinatal acquired HIV because we think their case is different from those that have actually acquired HIV themselves later on in life. And in this case, we are looking at a young man, John, who's a 17-year-old boy with perinatal acquired HIV. He recently found out that he was HIV positive, and when he fell ill and was admitted to the hospital for 8 days. And then after sharing the news with his girlfriend, she broke up with him. And since then, his good work has also been suffering. His marks have been falling down, his grades have been dropping, and he's not been taking his medications regularly. And he has also been self-medicating and with substances, and has also been depressed. And his teacher is now referred him to the school nurse. Now we meet John at the outpatient department where he's been by a health specialist. Next slide. Here we have the objectives. We've got 5 objectives here, and listed with the objectives, we've got the different activities that we, the facilitator will engage with the students. The first objective there says, explain the psychosocial and biomedical impact of perinatal acquired HIV. And what we want the group to do here is to discuss the impact of and the intervention to address the psychosocial and biomedical impact of perinatal HIV infection. Here we want the group to consider John's case and how his HIV has affected him. So the facilitator will lead the group in discussing the potential psychosocial and biomedical impact of the perinatal HIV for John and other people with the perinatal infection. And then using an ecological model, they consider the individual factors, family factors, and community factors, and then consider the potential resources and interventions that can be used to support John and the other patients. And the second objective there is discuss the strategies to address poor adherence to ART in adolescents with HIV. We might recognize that it's very difficult for adolescents to adhere to any type of treatment, and it's even more so with the adolescents with the HIV. So what we expect people to, the group to do here, to discuss the barriers that John and other adolescents with HIV may face with adherence to ART, and also look at how you might actually assess the adherence in these patients, in this population, and how you might address these barriers that you have identified. 3, demonstrate the effective communication skills with an adolescent patient. Mike has just gone over the importance of communication, and it's even more important when you're communicating with the adolescents. Even when they are not ill, we have problems communicating with our children, especially adolescents. So this becomes very important because we are all, we want them to want to work towards our goal to making him feeling better, and then that has got better health outcomes. So here, communication with adolescents certainly can be challenging. In effective communication occurs when the health professional and adolescent patients share an understanding of the message. Understanding how to effectively communicate with the adolescent patient is essential to their care. And then, discuss with the group to find out, like what are the barriers that can actually affect the barriers to effective communication with the adolescents. And also, you might ask the group to think back, reflect a time when they were maybe in the hospital, and that where they to gain trust of a health professional, find out if they can document or list those professional characteristics that help them to describe or to decide or to trust to trust the healthcare professionals. And the 4th objective there is describe the strategies to address mental health and substance use and strategies to integrate this with the HIV care. Here we just want to discuss, in the group to discuss assessing for depression in adolescents. How would you assess, the patients that are coming into, for treatment, how can you assess the adolescent for depression? And how can you incorporate this in your practice? And when would you refer the patient for help? So what you do is we want, the facilitator to work with the students and give them some time, 3 to 5 minutes, where they brainstorm and see how they can assess the students, how they can assess the adolescents, and then get information. And also, if let's say they find the student is depressed, how can they refer the student to a specialist who can now deal with the this aspect of depression in the young person. And we all know that it's very difficult that an adolescent will come up with information to tell us how they are feeling and all that. But we sort of saying, people should discuss that, whenever you see this adolescent, you need to pay attention to certain aspects of the patient. For example, you look at the physical appearance. Do they look smart, shabby, clean, pay attention to their hygiene and the grooming, and also the mood and, cognition, orientation, memory, concentration. So, a quick snapshot of that and see how the adolescent is doing. You may also need to consider a depression tool that you can use. For example, you can use a PHQ 9-score tool that would actually, where you suspect there might be some depression there, you just make sure that you do an assessment to see whether the adolescent is depressed, and then you refer the young men for further treatment. The last objective there is demonstrate how to refer a patient to a specialist for drug resistance, HIV. Here we employ the use of a ESPA to practice how to refer a patient. So those who have acquired HIV perinatal have often been exposed to many classes of art. Like maybe, this child is 17, he could have been given different forms of art, different level, first, second level, and all that. So you might find that the chances of getting drug resistance are quite high. Now, if you consider this is that maybe his recent viral load shows 40,000 copies per milliliter, and you are concerned about this new drug resistance. So how would you refer that person for further treatment? And then using as ESPA as a framework, you might actually get the student to practice to refer the patient to a specialist for further management. The next slide, please. Okay, now if we look at the key questions here, what learning methods are we employing? Most of this, the method that we're employing is a small group discussion. We're also using role play. The student, playing the role of a patient. The different teams being assigned different roles, in the ESPA to make sure that they come up how they will refer the patient to the next level. Trying to communicate here. We are looking at the communication, especially the communication, which can be difficult at times. So it's something that's very sensitive, but we want to make sure that our students learn how to communicate with the adolescent to get the right information, and that they don't miss anything that will be detrimental before the patient goes home. We're also looking at the issues of disclosure, because it's very difficult for young people to disclose, to their friends, to family members, even to the healthcare workers. We're looking at how can we help them, how can we help the family disclose so that the patient can be managed better. And what are the essential IP tools that we are deploying, and also what is the QR method addressed in this module? For both these questions, we've used the ESPA, as an IPE tool, and also to address the quality improvement method tools. So this worked very well for us because we used it, also to address the IPE aspect and also the quality improvement tool.
Thank you, Clara.
Yes.
Next slide. Oh, great. Okay. So I want to say a comment about Module 6 on PrEP. And so there was a reference to videos being prepared showing a positive encounter with a provider on taking a sexual history, and then or the positive one being non-discriminatory, and then a negative encounter with providers judgmental, very superficial, and these are her questions. The videos are actually being prepared right now, and so we hope to release them next month. So for institutions that are using Module 11, we're open to creative ways to teach that activity. You can talk about that if anyone, you can reach out to our Stripe at Stripe HIV email with questions. So for next week, we have 13 and 14. 13 is on health systems, 6 pillars of the WHO 6 pillars of health systems. And then 14 is on community-based service delivery. So we bring in differentiated service delivery models. So trying to get services out into the community to decongest facilities. So thank you everyone for joining, and we will meet back here next week.
Cheyenne, can I just jump in before we finish? Just to say a couple of things. One is Clara and Judy, thank you so much for your presentations and also for your leadership on this process and your expertise in interprofessional education. Both of you are giants in this domain, and we're grateful for your contribution. I wanted to say a couple of things about the project at large. So next week, we hope to be able to share with all of you what the Stripe website will look like, which is about to go live. All of your PIs will be hearing more about this over email, but on the next webinar, we hope to be able to sort of update you on the website. And then moving forward, our feeling is that these afternoon webinars on a Tuesday are a successful way for us to meet together, and we would like to continue that even after we've reviewed all the modules, and use this as an opportunity to hear about what you're doing at each of your institutions, how the Stripe project is going in Zimbabwe, in Uganda, in South Africa, wherever you are. And so that is our goal moving forward after we've covered the 17 core modules. So we may not meet every week. We may move to meeting every other week, but we welcome your feedback on this. Our hope is that this convening will be a way for us to meet as a team across different nations and truly embody interprofessional practice as we connect over the internet together. So as Cheyenne said, thank you all for joining. We're grateful for your contribution and the energy and enthusiasm that you are all investing into this project. And finally, the recording of this webinar, as well as other resources, will be in an email that will follow later today, and in the calendar update, the invite update that you will receive in your inbox at some point in the near future. All right, thank you guys.
Thank you, Mike.
Diane, thank you all. Bye-bye.
Bye. Thank you.